All right, so good afternoon. My name is Rami. I'm associate professor at the College of Pharmacy of Xavier University of Louisiana. And so what basically I'm gonna do is talk about the non-active site inhibitors of clotting factors as potential new anticoagulants. And what I mean by an active site is basically those are the allosteric inhibitors, means they target other sites other than the active sites. Clotting factors are serine proteases, potential new anticoagulants, so which means we're going to use them to treat thromboembolic diseases. Do we have anticoagulants in the market? Of course we do. We do have anticoagulants that include the indirect ones, conventional ones, heparins and warfarin. And we have the newer ones, and those are thrombin and factor XIa inhibitors. However, all of these, clinically used anticoagulants are associated with significant risk of internal bleeding, which basically limits their use for certain patient populations. For example, you have patients with chronic kidney diseases, they're already at elevated risk of bleeding. So if you add anticoagulant to them, that would really compromise them further. Patients with atrial fibrillation, they are at increased risk of bleeding. And in fact, 50% of them, they are not being treated with anticoagulants just because of the fear of bleeding. The other 50% are being treated with reduced dose that's not effective. So given all of these, or given this serious side effect, our intention was to develop new anticoagulants that are not associated with significant risk of bleeding. Although, as I said, we have newer ones, right? We have factor XIa inhibitors. All of us really watch TV and see advertisement for Eliquis. That's I believe Bristol Myers Squibb. We see Xalerto, that's rivaroxaban. Well, they did transform the treatment, but if you consider basically the rate of major bleeding or clinically relevant non-major bleeding, in comparison with the state of art at the time, you continue to see a significant rate of bleeding, even in these patients who are using the newer drugs. So as I said, this is the current anticoagulation therapy where we have very effective drugs. However, they create this problem of bleeding. Literally, if you see somebody who's using these on a regular basis, you will see their hands with the bruises, right? And in fact, in case of warfarin, which is rat poison, intracranial hemorrhage can happen. And if that happens, mortality rate is 67%. So what we would like to see in future is basically, anticoagulant where we have balanced efficacy and safety. As I said, this side effect of bleeding happens irrespective of the structure. So it's a mechanistic thing. Of course, all of the available anticoagulants, they do have their own other side effects. For example, the newer drugs you can't use in patients with compromised liver, with compromised liver function, heparin osteoporosis, risk of contamination, and so on and so forth. But all of these other side effects are actually structural aspects or structure-dependent side effects. The bleeding appears to be mechanism-driven side effect. Why is that? Because all of these available ones target two proteins in the common coagulation pathway, and that's factor XIa and or factor IIa, which is thrombin. That's the common coagulation pathway. So all of these drugs that are available in the market, they inhibit directly or indirectly factor XIa and or thrombin in the common coagulation pathway. And therefore, what they do is they shut our ability to clot. In other words, they block the formation of the pathological clot, and also they block or they prevent the formation of the physiological clot, which is the hemostasis. And therefore, bleeding happens. So what is our suggestion? Target other proteins. We have 12A, 11A, 9A, and we have 13A. And we do have some projects to target 12, target 13, but I'm going to talk about 11A. Why? Because there is more really evidence toward targeting factor 11A being a good strategy to come up with anticoagulants without bleeding. I'm going to give you one example. And the example is hemophilia type C patients, Ashkenazi Jewish. Those individuals have no factor 11A. They are better protected against thrombosis, and they do not bleed more than normal unless you challenge them in surgery, which tells you if you inhibit this protein, you're likely gonna come up with a drug protect against thrombosis, particularly venous thrombosis, and you're not gonna create the side effect of bleeding. The way we do it, allosteric inhibitors of factor 11A, allosteric because all of these serine proteases, and all of us know allosteric binding sites, you know, they are not as conserved as the active sites. So it's easier to come up with a selective agent. We have SCI. Basically, it's a heparin mimetics, similar to heparin in structure. However, mechanistically is very different because it targets factor 11. And you see, this is a result of chromogenic substrate hydrolysis assay, in which we see that the IC50 for this molecule is 280 nanomolar, and it is selective toward this enzyme over other enzymes in the clotting factors, thrombin 10, 7, 9, 12, 13, plasmin, plasma kallikrein, and digestive ones just for demonstration of selectivity, trypsin and chymotrypsin. Here's the inhibition profile. Mechanism kinetic, as you know, decrease in Vmax, no change in Km is indicative of allosterism. Fluorescence-based binding studies, quenching-based binding studies, all of them really basically indicate that the molecule behaves in allosteric fashion. We have mutagenesis studies. Factor 11A looks like a cup and saucer. The cup is the catalytic side. It is the catalytic domain, where we have this color right here. The orange color is the active site. The blue colors are potential allosteric sites, and those are anion binding sites, means they engage with molecules that have negative charge. One of those is heparin, for example, although heparin clinically is not important when it comes to factor 11A. We did reversibility studies. It can be reversed, although we don't need it. Effect in human plasma. You see that there is an effect on ABTT. ABTT stands for activated partial thromboplastin type, which measure the clotting when you trigger it by the extrinsic pathway. And that's where we have factor 11A. No effect on BT, that's prothrombin time, which means no effect on 7. So that is indicative of functional selectivity. Then we have more studies to, try to establish that this molecule is physiologically relevant. As I said, the assay is done by chromogenic substrate hydrolysis assay. So we use non-physiological substrate. So what about establish the physiological relevance of this molecule? So here you use the actual physiological substrate of factor 11A. If we go back to this representation, we see that what factor 11A does is to activate factor 9 to 9A. Now we wanted to see if our molecule does impact that process, and indeed it does. As you see here, activation happens within 30 minutes by factor 11 on 9 to 9A beta. When we use the molecule, there is no activation whatsoever. So this established the fact that the molecule is not inhibiting factor 11A using the non-physiological substrate, but it does that by even using the physiological substrate of the enzyme, which is factor 9. We established further the selectivity of this molecule in human plasma. We run these human plasma assays where we get antibodies, knock out the protein, and then use our molecule. And in this condition, we don't see any effect for our molecule after we use the antibody that's specific for factor 11A, which is, once again, really substantiate the fact that our molecule is selective even in a human plasma. We have done studies in human whole blood using thromboelastography. We have done studies in human whole blood using hemostasis analyzer system. We measure different parameters, and we always see things consistent with the anticoagulant effect. And as you see, everything here is concentration dependent. And then finally, we moved to in vivo, where we wanted to establish things. in animal. This is rat. We tested this molecule in arterial thrombosis model as well as venous thrombosis model. We use enoxaparin as a positive control. Very similar effect in arterial thrombosis. No significant difference between our molecule and enoxaparin. For venous thrombosis, we do tail bleeding assay, right? And basically our molecule is behaving much better than enoxaparin. In other words, it doesn't extend the bleeding time. It doesn't increase bleeding or blood loss. There are potential uses. We look for, to substitute heparin.
Wrap up really quick.
Okay, yeah,
Yep.
that's the last one. We look to substitute heparin. Heparin continues to be a major anticoagulant, although it is old. 60% of heparin supply comes from China. There is a risk of contamination as it happened in the year of 2008. There is loss of so many pigs back in China because of the flu, and therefore there is a limitation on the supply. So what we propose is to use this molecule in clinical settings to substitute or complement the use of heparin. These are future studies. This research partially supported by NIH. Thank you.